What kind of fruit has the most electricity in it? Did I already say this one? Okay. What kind of fruit has the most electricity in it? A watermelon. Watermelon. What has 2 holes and no legs and runs? What's that? Your nose. Well done. Why does DNA have no fashion sense? Why does DNA have no fashion sense? Anyone? It always wears the same old jeans. All right. That's a delayed laughter. It's okay, I'll take it. Sometimes you got to take what you can get, you know? It's like, it's not that funny, but courtesy laugh, I appreciate it. All right. Yeah, I do. Very much dad jokes. They're very much dad jokes. You could probably close your eyes and picture your father saying some of these. That's yeah, exactly. That's what makes it that much more special. Okay. You should write some of these down, and then at Thanksgiving, you can actually reverse dad joke. Okay, and he'll be on the floor. Just don't let him choke on his turkey, okay, when he's laughing so hard. All right, so a couple of questions have come up. So let me answer a few of them. So today's material is actually game on for the exam, and I had hinted at that last week. We don't have a lot. We'll actually finish early today. The exam on Wednesday should be no surprise, kind of very similar format, similar organization, 50 multiple choice. I think there's 8 questions on the screen. There's 8, so it's a little bit heavier on the images, but you can probably appreciate when you review. You can kind of think through muscle physiology and what image questions may I pull from, and then also CNS, what image questions might I pull from. Okay, so there's a lot of figures and imagery and understanding how things fit together or slide across each other or stuff sticks to them and then they move, right? You following? Left versus right brain. A question came up, like, what do we really need to know about left versus right brain? Well, there was a slide, there were 2 slides, they're back to back, a couple lectures ago, about areas or specialization centers for the left brain versus the right brain, right? And that was kind of this joke, which nobody really laughed at, okay? So, right side, creativity, you know, there's centers for music. There's a slide that kind of shows you what centers are located in which hemisphere. And what's the structure that connects the 2 hemispheres? What's it called? Corpus callosum. Is it gray or white matter? White matter. Okay. It's called a commissural tract. So it connects 2 big parts of the brain together, the left and the right hemispheres. Then I showed a picture of the brain from the left side, and we focused on speech centers. One was for motor speech, and it was located on the left frontal lobe, and it's called what? Broca's area. And then we talked about a speech center, left hemisphere, but towards the parietal lobe, and that's for comprehension or understanding, interpretation of what's being said. And what center was that called? Wernicke's. If I turn to this side, do Broca's and Wernicke's exist on the right brain? No, they exist on the left hemisphere, right? So those speech centers are on the left side of the brain. So that's kind of hopefully orienting you on the importance of being able to separate out the different hemispheres, okay, in different regions of the brain. Okay, so for today, to finish things out, and it's kind of for sake of completeness, and I'll kind of highlight areas that I think would make the most sense to dig into with respect to Wednesday's exam throughout the lecture. I'll give you those clues. Okay, I know it's 2 days before the exam. We're not going to have an hour and 15 minutes of new material. Okay, I promise. We're finishing out what we've already started. Some of the stuff I've already alluded to. So I'm going to kind of fill it out. There's a little bit of new material, but really not much. The major parts of this spinal cord, if you observe the spinal cord here, what I want you to be able to appreciate is the anterior portion is here, ventral, and the posterior, the dorsal portion, is here. We've got colored in red ascending tracts that go up to the brain. We have colored in green the descending tracts that come down from the brain and go out to the body. Okay? Ascending tracts go up to the brain, descending tracts go down to the body. Because one of the purposes of the spinal cord is to really connect the central nervous system or connect the brain to the rest of the peripheral nervous system. That's really, it's like the main highway to do this. So we've got a couple of features. Like you can see here, we've got gray matter and we have white matter. And the gray matter is consisting of the dorsal and ventral horns. So these are called horns as they kind of go from small to large, and they're made up of gray matter. So this little butterfly component that we've been looking at for the last few lectures is actually made up of gray matter. And mostly what that gray matter does, if it's a dorsal horn, it's bringing in information from the periphery. If it's a ventral horn, it's sending information out to the periphery. Make sense? Because we talked about how the posterior aspect is where a lot of the sensory information comes in from the back, and then the motor output is from the front. So you can save biological energy by not myelinating these because you're really here at the local level. We'll talk about some reflexes today where you get information coming in, it goes sensory into the back. You have an interneuron, a connecting neuron, that reflexes it right back out to the motor side. So it's at the local level, it doesn't need myelin because it doesn't necessarily need to travel up to the brain. But at the same time, the information from an interneuron may go over to an ascending tract and go all the way up to the brain, and these ascending tracts are myelinated or non-myelinated. They're myelinated because they're far away. It's a long distance to go. Okay, so now you have sort of this discrepancy in the spinal cord between gray and white matter. I actually think it makes a lot more sense, the division between gray and white matter, at the level of the spinal cord than it even does at the brain. Because at the spinal cord, anything that's local, that goes from dorsal to ventral root horn, is a reflex. And anything that actually goes up an ascending tract or down a descending tract, these tracts are descending tracts from the brain, usually motor output. They're also myelinated. Surprised? It's coming from the motor cortex of the brain all the way down to the spinal cord. There is a lateral horn for sake of completeness. I won't test you on that. But just so you understand, it's really only visible in certain regions. And that's why when you see kind of the traditional picture of the spinal cord, it doesn't show a lateral horn. It just sort of shows the dorsal and the ventral. So our spinal nerves, the spinal nerves that actually come in the dorsal root are exclusively sensory. And the spinal nerves that exit out the ventral root are exclusively motor. And there's stuff that comes in other areas, right? And the ascending tracts are located as a dominance towards the posterior aspect. These are sensory ascending tracts. But you can see that everything in red, like this is obviously not towards the back. But the volume, if you took a percentage, this is like the midline. There's less nerves going up that are anterior in this direction. If you did the midline here, there's most of them, the vast majority of them are towards the back. And it's the same thing with the motor. It's not 100% of the motor neurons are located in the anterior aspect. But if you kind of did from a sagittal cut here and divided this, a portion of this bundle is towards the posterior, but then really everything else is towards the anterior. Okay? So kind of the theme still fits, and what I shared with you previously still fits. Okay, I want to talk a little bit about how nerves are packaged. Now, this is a slide that we've alluded to. Should be pretty straightforward. What are some other things that structures that you've come in contact this semester, excuse me, that have this kind of organization? Skeletal muscle and bone. I would say skeletal muscle even more so than bone, but bone still has the same architecture. And this is a slide that kind of connects our central nervous system as we leave muscle physiology. We're going to have an exam on Wednesday, and then we're going to start the nerve physiology next week. And so we'll kind of revisit this slide next week as we get ready. But for sake of completeness, now you kind of understand the anatomy, the architecture of this sort of butterfly slice. You understand the difference between dorsal and ventral roots, sensory towards the back or dorsal, motor towards the front or ventral. If you look down here at the level of the nerve fiber, similar to muscle, you can kind of appreciate that some of these are myelinated, others are non-myelinated. And the unmyelinated and myelinated fibers aren't in completely separate camps all the time. They can be in close proximity to each other. It just depends on where they're actually going. So the myelin around the nerve fiber is surrounded by an endoneurium. You have a number of these nerve fibers. Surrounding them is this perineurium, creating this nerve bundle. And then a number of these fascicles together create the entire nerve, which is wrapped with an epineurium. And here you can kind of appreciate the scanning electron micrograph, where these large openings are the vascular supply to keep the nerve, which is highly metabolic, to keep the nerve alive. And I've alluded to this parathesis phenomenon, where I never referred to it as that, but parathesis is not paralysis, but it sounds like it. Parathesis is the stunning of a nerve, typically due to a loss of oxygenation. So it happens when you're sitting in this class and you have your legs crossed, you're sitting on your leg, and it falls asleep. That pinprick feeling is parathesis. That's the early sign of nerve death, because you've shut off the blood supply to the nerves and they're detecting low oxygenation. So to get your attention, they send a signal that's a I'm dying signal, and that's that pinprick feeling when your foot goes to sleep. Now, later in your career, later in your coursework, you'll learn a little bit about this connection with unmanaged end-stage diabetic patients that have parathesis. They have this numb pinprick feeling all the time. It never goes away. So they have poor perfusion of the distal extremities. One of the first early signs of diabetic neuropathy, that's in a diabetic that's unmanaged, the nerves are dying. That's what that means, is that parathesis feeling that never goes away. Now we have medication to kind of calm that down so it's not so uncomfortable, so they can fall asleep. Because can you imagine trying to fall asleep with your foot like pinprick feeling at you? It's really annoying. So that's kind of the architecture of the nerve and where a lot of those things come from. Okay. So it's important for you to understand sensory, motor, ascending versus descending for Wednesday. It's also important for you to know that this information that comes from the periphery as it's on its way up, it actually decussates, or it crosses over. And I actually indicated that in a prior lecture. We're going to walk through where that exactly happens in this slide. So here's the brain up top. You can see down low, we're at the level of the spinal cord, somewhere in the periphery, we're receiving information. that's from body movement and limb position. And that's coming in, characteristically, the dorsal root horn. And it's coming in from the patient's right side. You appreciate that? Anatomical position. So it's like this. It's coming in from the patient's right. It actually travels up these ascending tracts, and at the level of the medulla oblongata, it actually crosses over to the patient's left side, and this word is decussates. And then it continues up, ultimately, and it goes through the thalamus, which is the relay center. Ultimately, it ends up here on the post-central gyrus, which is that somatosensory cortex that we learned about. Now, not all information completely crosses over. Like, so we've got the ability for there to be ascending tracts or tracts that move up to decussate or crossover, which is the vast majority. Hemidecussation is where you have half of the signal crossing over and the other half staying on that same side. This happens with the optic nerve. So when you get information from one eye, half of the information goes to the other side of the brain, vision cortex. The other half stays on the same side. So we have terms for that. Contralateral is the opposite side. So you get information coming up, it decussates at the level of medulla, the information goes to the contralateral side. If the information stays on the same side, that term's called ipsilateral. So information that comes in from the right eye, half of it crosses over, decussates over, not at the level of the medulla because it's in basically more of the main part of the brain. Half of it crosses over to the occipital lobe, and that's on the contralateral side. Half of the information stays on the same side, or ipsilateral. Right? So you'll see these clinically because the same thing happens. We're going to look at this. The same thing happens on the motor cortex. So now we're going descending tracks, going down. The descending tracks primarily are going to be located towards the ventral, the anterior portion. But you can appreciate up here from the motor cortex, which is the precentral gyrus. We get information coming from the patient's right and from the patient's left. They come down descending tracks towards the anterior portion. They get to the level of the medulla oblongata, and the left information crosses over to the right side and continues on its path down. And the right information crosses over at the medulla to the left side and continues down its path. There are all of these lateral corticospinal tracts, ventral corticospinal tracts, not necessary for Wednesday's exam. But I want you to be familiar with the terminology. If it's a lateral corticospinal tract, it's a tract that's located on the lateral aspect. It connects the cortex, right, to the spine. That's what that word means, lateral corticospinal tract. So it's not rocket science, but it sounds crazy complicated unless you just dissect out the terms that you've been learning this semester. So similar to ascending tracts or sensory tracts, descending tracts or motor tracts decussate at the same structure, so you only have to memorize the medulla. The medulla is the right answer, whether it's going up or whether it's going down. You with me? There could be questions on the exam. Questions, I like to have some of these like clinical correlations, real world example questions of, patient has a stroke of the motor cortex on the left side. Which of the following would you expect there to be problems associated with? And it's going to be like some motor activity on the left, some motor activity on the right, some sensory information on the left, some sensory information on the right. Does that make sense? So I can have 4 answers from that one question, which is a nice multiple choice A, B, C, or D, and then maybe one distractor question to fill out E that doesn't make any sense according to the information that's being provided. You follow? Question. It's a great question. I don't know the answer to that. So the question was, what is the purpose of the decussation? So one of the theories is, like, during the process of evolutionary development, there could have been value in having information that crosses over or hemidecussates, and you get the same information to both sides. And then as we continued to evolve and the corpus callosum became more pronounced, the transfer of information from the left to the right side, you didn't really need to do that at the level of the brainstem. So that's one theory, okay? But nobody really has been able to answer that question. It's a really good question. Why? Because you see these things, you're like, well, why bother? Why, you know? So most of the answers that I've read that seem reasonable are it's, you know, some, not relic, but, you know, something that's still left over from an earlier time in development when the left and the right side of the brain weren't as fully communicating with the corpus callosum. The corpus callosum is a pretty amazing track system. In fact, there's patients, we don't really do this anymore, but there were patients that would have like pretty aggressive seizure activity or grand mal seizures, and where there's stimulation of a portion of the brain, and then it propagates from one part in the right hemisphere all the way across to the left hemisphere, and they'll have, you know, grand mal seizures where they could actually expire. And so 30 years ago, before a lot of the medication, the anti-seizure medication was prevalent, if it was really extreme, they would actually sever the corpus callosum. And they would do brain surgery and have two separate hemispheres. And there's other association tracks, but not the main corpus callosum track. And so there's actually video, like if you go to my YouTube and you go to pathology, there's some old like VHS tape video that I converted to digital, because VHS was never on YouTube. So it's really poor quality, but you can see an interview with a patient in my pathology class. And you can go there now. You don't have to be in pathology. It's free. It's on YouTube. And you can watch the interview, and there's a patient who is talking with the psychiatrist, and the psychiatrist says, "Can you put these things in order?" And so, you know, he'll start putting things in order with his left hand, and then his right hand will start moving it around, and then his left hand will come here, and his right hand will grab his left hand, like literally grab his left hand and tell him to stop doing it. And the psychiatrist is interviewing the patient. And the corpus callosum has been severed in this patient. It's like a film from like the 70s or 80s. And I ask him, like, well, does your hand, the bad behaving hand, bother? He's like, oh yeah, it bothers me. I want to just cut it off. And you're like, whoa. Like his hand is literally, it's a non-dominant hand that is disobeying him, which is weird, okay? So I digress, but the theory is before that corpus callosum was prevalent, we had a really valuable reason for sending the information or making a copy of the information. It was probably a hemidecussation versus a full decussation. Okay, so not going to test you on memorizing all these tracks, but you'll probably see something like this in the future in your coursework or in your clinical experience. And so, for sake of completeness, you don't need to study it for Wednesday, but I do want you to be familiar with some of these terminologies, right? So we talked really about dorsal, we talked about ventral, we talked about dorsal root horn, ventral root horn, but you can see this is a dorsal spinal cerebellar tract. So where is it located? It's more towards the posterior aspect. Where do you think it goes? To the cerebellum. Yeah. Okay, likewise. Let's look at this one. This is the lateral reticulospinal tract. Where do you think this went? This is motor, so where did it come from? From the reticular formation, right? Yeah, so anyways, I just wanted you to be able to appreciate, like, there is a nice organization of the spinal cord where you kind of bundle the axons as they travel up and as they travel down. How many of you are kind of like techie? Like you like computers? No? Nobody? Okay. How many of you like have opened up a closet like in the university and you're in like the computer room and you see all the flashing lights and then you see like bundles, or you've been in buildings that are more like industrial and like there's no ceiling tiles, everything's exposed, and they have like trays and they have like bundles of wire and they're all zip tied and they're nicely neatly organized and you can see where they're, you know what I'm talking about? That's what I envision of how our spinal tract is organized. Kind of like those, you know, kind of industrial buildings where they have all of the IT cabling going where you can see it, because if there's an outage, it's easy for them to figure out what went wrong. Okay, let's talk about plexi. So plexi is kind of a weird term. Plexi is the plural. The singular is plexus. We have a cervical, a brachial, a sacral, and a coccygeal plexus. We actually have nerves that are in a, you know, intersecting network, but they're not technically referred to as a plexus in the thoracic region. Really, all a plexus is a network of intersecting nerves. So it's kind of like that computer IT example I just gave you, where you've got these bundles that come out of the cervical region, bundles that come out of the thoracic, but technically not a plexus, bundles that come out of sacral, coccygeal. I skipped the brachial. And let's just look at cervical on this picture and talk about where these things go, because this is setting us up for the periphery, which we're going to next. We're talking about nerve physiology, then peripheral nerves. Okay, so C5, C6, C7, C8, and then thoracic 1. So these are at the level of the individual vertebrae. And you can kind of appreciate here at C5, we've got this nerve that comes out that actually branches into a lateral cord, a musculocutaneous nerve. There's a branch that kind of connects to the median nerve. At C8, you've got connections that actually come back up to C5. You have it coming to the median nerve as well as the ulnar nerve. So do you see how these are intersecting networks? And at the level of the thoracic region, it doesn't have this kind of intersecting pattern where one nerve actually kind of connects to multiple locations. But this is the reason that spinal cord injuries are so unpredictable. So maybe you've had a loved one or a friend or somebody that you knew, or you've seen this in the movies. Somebody gets in a bad car accident and they fracture the spinal cord, right? They broke their back. They broke their back. What's going on? Well, they don't know yet. They're waiting for the inflammation to settle to determine the extent of the damage. They're a little nervous that there's going to be some paralysis. Like, oh, really? So, for example, if you're a C7, let's make it more simplistic. If you're superior to a C5 injury, then you're probably going to have a quadriplegic paralysis. If you're down at the level of inferior to C7, there actually may be some use of the upper appendages of the arms, right? Obviously, further inferior is better. I know this sounds horrible. Better in the case of like better clinical outcomes. But if you're, inferior to C8, you're probably going to be paralyzed from the, waist down, but you'll have full mobility of the left and right arm, right? So this is the C5 to C8 is where it's really unpredictable, because you've got so much of this crossover of nerves because of the importance of controlling our hands, right, and our limbs. Okay, a review question. Ascending tracts, also referred to as afferent tracts. And then descending tracts, the term is what? Efferent with an E. So descending efferent tracts are motor tracts. Ascending afferent tracts are typically sensory. So what's the right information here? Right answer. A. Okay, beautiful. Okay, we're going to talk a few minutes here as we close about reflexes. So here's a potential question that I think really kind of summarizes best how you might put all this information together. So left postcentral gyrus receives information about the texture of a fabric you're touching with your hand. Along which spinal nerve did this signal enter the spinal cord on its way to the brain? You've got 5 options. Raise your hand if you think you got it. Okay, you were first up front. It's going to be A. Why? Correct. Correct. All right, anatomical position. So if the left postcentral gyrus receives the information, it must have decussated at the medulla. It came from the right side. It came from the right side of the patient. Is it coming from the anterior or the posterior aspect? Posterior aspect, so A is the best answer here. Okay, can you imagine how I would write the question if I wanted a motor? Okay. Okay, so now let's put this to use, this information. And we're getting more and more, there's not this nice clean division between the central nervous system and the periphery. Okay, so this is kind of the part of the lecture where we're kind of teetering on both sides. We're starting to talk about peripheral things. But you can't really appreciate the peripheral if you don't understand the central, and vice versa. You can't really appreciate the peripheral if you don't, or the central if you don't understand the peripheral. Okay, so we're going to talk about reflexes. Reflexes are a really powerful tool of how we interact with our environment. And there are 4 main characteristics of a reflex. 4 main characteristics of a reflex. Number 1, they're stereotypical. Stereotypical mean they're the same every single time. They're quick or rapid. A reflex happens very fast. Number 3, they're involuntary. You don't have to think about them. Involuntary. And then number 4, they need stimulation. So they respond to some sort of sensory input. So now we're going to look at some of the different structures that are involved in a reflex. So we have 4 main characteristics. Now we're going to look at a number of different structures of a reflex. So for example, we have a sensory receptor. So we're going to talk about 2 today that I want you to be familiar with. We're going to talk about a muscle spindle and a Golgi tendon. So the muscle spindle is found within the muscle. It's embedded in the muscle, and I'll show you a picture of it here in a minute. But for now, for all intents and purposes, just sort of appreciate this little white structure that's inside of the muscle. This is a cutaway image, and that's a blown up diagram with the membrane of the muscle spindle dissected apart. That's important for you to understand. It doesn't have like this mouth-looking structure. Like this has been cut open and opened up so you can see inside of it. But really all it is a receptor, a sensory receptor. That's all this is. So you're just having a sensory receptor inside of the muscle itself. It's going to send a signal. It's going to send a signal by a primary afferent neuron. Afferent neuron. This afferent neuron is going to go to the dorsal aspect. There's a signal that's going to go up to the brain. It really should have this arrow from here because this isn't 100% correct. I don't love that part. I love the figure except for this arrow. This arrow should actually have a innervation onto this dorsal column, and then the arrow should be originating from here and go up because it actually goes up the white matter. But then there's an interneuron that actually connects it here to a positive signal, and then connects it here to a negative signal. So the negative signal, the inhibitory signal is in blue, and the stimulatory signal is in red. And if you follow those blue and the red tracks, one goes to the working muscle that you want the activity to happen. The other one goes to the antagonist to prevent it from interfering. Okay? So the analogy would be, you touch the stovetop and you move your hand away, right? You're pulling your hand back. So you're going to go through a arm flexion. So you want to inhibit the arm extension. So you inhibit the triceps and you actually activate arm flexors. Make sense? Otherwise you'd be like, oh, you're fighting yourself. You have to send two signals, one to inhibit triceps, one to stimulate biceps. So it's quite complicated, and this all happens without you thinking about it. But that's a reflex. So we have the different parts. We have the sensory receptor. We have the afferent neuron. We have this interneuron. The interneuron is like an association neuron or a connecting neuron. They're typically found within the central nervous system. Interneurons almost exclusively are within the central nervous system. Then we have an efferent neuron that leaves, and this is all happening within the horns in the gray matter, like I said before. The only information, you can correct this drawing and put the arrow up to the brain here in the white matter, but the effector organ, it goes from there's two effector organs. There's the extensor and there's the flexor. And those are the effector organs. Now, if the effector organ is like skeletal muscle, like we see here, then we refer to this as a somatic reflex. If the effector organ is smooth or cardiac muscle, we actually refer to this as a visceral reflex. So today, and for Wednesday, we're only going to talk about somatic reflexes, and there's only two that we're going to talk about. So the first one, as a continuation of this slide, is the muscle spindle. The muscle spindle, this is important, detects information about changes in muscle length. The muscle spindle gives you information about changes in muscle length. Gives you information about the muscle's position. How close are you to the end of where the muscle can flex? Right? You've experienced this, right? You've done an activity or an exercise, and you get to a point you're like, oh, I don't know if I can go any further. Oh, right? Like your brain is telling you, oh, stop that. I don't know if I should go any further. That's feedback from the muscle spindle about muscle length. Muscle length. It's a safety mechanism, so you don't tear your muscle. So again, this is a picture. It looks a little complicated, but this is typically, this side is connected to this side. So imagine that's like folded over, but we've kind of filleted this open and then opened it up so you can see inside. And it's this wrapping with these yellow fibers, and it's in a spindle-like fashion. And then when you close this, it's kind of a spindle where it's thin on the beginning, kind of wider in the middle, and then thin on the end. And that's where it gets its name from. But it's literally a sensory nerve inside the muscle itself, giving you information about muscle length. Okay, so practically speaking, how would this work? So here's an example. You've got two motions here on this reflex. You've got one motion that is drawing your right foot, I better stand this way, your right foot up into flexion, and the other motion that's extending your left foot, your left leg, excuse me. So you have right leg flexion while you have left leg extension. You with me? Because if you flex both, you just fall over. And the whole concept is you've stepped on something like a piece of glass, it's painful, so you're sending signals and you're getting information from the muscle spindle about where you are in space so that you can actually execute on this semi-complicated motion without even thinking about it. You walk in shallow water in the ocean, you step on something sharp, you're like, ooh, ooh, ooh. You're automatically on one limb, and you didn't even think about it. That's the muscle spindle and how it interacts with this reflex, which is called the flexor withdrawal reflex. Okay? Okay, so the last example for today, and again, take-home messages, really focus on muscle spindle and Golgi tendon and those information. So the Golgi tendon is located kind of at the end of the muscle where it terminates into the bone or where it inserts into the bone. So these are proprioreceptors. These proprioreceptors respond to changes in muscle tension or force. So the muscle spindle is length, right? Length and position. And the Golgi tendon is muscle tension or muscle force. So the idea here on how this works is if the quadricep muscle group contracts, right? That's your thigh muscles. And when these contract, they extend the leg, right? So when the thigh muscles contract, the tension in the Golgi increases. And this stimulates neurons serving the contractile muscle. It stimulates muscle stimulates muscle in the antagonist, and it inhibits muscle in the agonist, so that the muscle tension doesn't go too far, and you contract here and blow out your own knee. Right? So the muscle spindle is length position. The Golgi tendon is tension. So when the tension gets too much towards the end of that motion, you're sending reflexes to actually inhibit your quadriceps and actually stimulate your hamstrings. And another protective mechanism that's really important as we are in motion, and think about the motions that we do. They're complex motions. And most of the time when you're walking or when you're exercising, when you're moving, you're really not thinking about this stuff. You're really not thinking about this stuff. But it also kind of translates to like sports injuries. So let me explain. You're an elite athlete, highly trained. You've done this activity or this route or this competitive motion for thousands of hours. Now you introduce a new variable, and you've got all this feedback from your muscle spindle and your Golgi tendon, right? And here's the new variable. You're playing on a field that is slightly uneven, right? There's a little pothole right in the middle of the field. You run the exact same motion, all of the quote-unquote muscle memory, right? You see where that word comes from? All of this sensory information that you've programmed in your brain, in your somatosensory cortex, and then your precentral gyrus to send out motor control, you've done this thousands of times. But it's a new field. Maybe it's a little wet outside, so it's a little slick, and there's a slight little divot in the middle of the field, and you contract too hard at the wrong moment while you're moving this way, right? And there goes an anterior cruciate ligament. Now, the ligaments and the tendons don't have this feedback. It's just the muscles. So the next obvious question, right, Dr. Keller, is, well, why? Why don't the tendons? I don't know. I wish I did. Maybe because it's a lot of biological energy to develop these in utero, and we focus on the muscles, and the muscle gives us the control. Okay? You can't control everything, so you control the way the muscles move. But this is one of the reasons that we have a lot of athletic injuries. Many of you will be treating athletes with injury. And oftentimes you'll be like, I don't know what happened. I was just, I just heard a pop. But what were you doing? I was cutting to the left like I always do. It was no big deal, right? What was different? I don't know. I was a little tired that day, right? or the field was a new field. Make sense? So, last little picture here to kind of tie it all together. So here's our quadriceps, which are our extensors. Here's our hamstrings, our flexors. Here's our central nervous system. You can really nicely appreciate this Golgi tendon organ is sending a signal into the dorsal aspect. You've got these interneurons that are nicely labeled, see in green, and they stay within the central nervous system, just like I said. And it stimulates both interneurons, but here on the motor efferent, one is stimulatory on the purple, stimulating the hamstring flexor to control the extension, and in red, inhibit the original working muscle of the quadriceps so you don't overextend. So this is biofeedback. This is how you're controlling the way you interact with your environment. You don't even have to think about it. It's unconscious. It's the same, remember? It's stereotypical. It's the same every time. It's rapid, involuntary. And then you add some new equation, something small, like the grass is a little too long. You laugh, but there are athletes who be like, what happened? Well, the grass was really thick that day. Like, and you tore your ACL? Like, yeah, it felt weird. It was so different. Okay, questions? True to form, we are done. 28 minutes early. Happy to stick around, answer any questions. Hopefully I helped you really kind of focus the new material.